Good afternoon, everyone. I would like to welcome you to the 7th session of our ECHO program. And today we are looking at early infant diagnosis. As we know that HIV in children is quite an important topic, and we have to start with diagnosis so that we can understand the mechanisms that are involved in identifying children who are infected with HIV. My name is Dr. Francis Mpeta, and I'll be your facilitator this afternoon. And with me is a co-facilitator, Madam Nomsa Simwanza. And today's presenter of the didactic case is Dr. Chalirwe Chungu from Pediatrics. We've been joined by several spokes, and I can see from here, Chilenje. So quickly, if we can introduce ourselves under 30 seconds so that we don't waste much time. Chilenje, you may introduce yourselves. Chilenje, are you ready?
Hello, good afternoon. This is Chilenje Level 1. My name is Patrick. I'm the HIV TV clinical mentor, and in our midst, patient, so some other members will be joining us shortly.
Thank you very much. We move to Chipata.
Good afternoon. This is Dr. Lusa Chipata and Mambwe lead mentor. Thank you.
Thank you very much. Are you joined by anyone there in Chipata?
Not yet in. There's the IT specialist, Mr. Nkata.
All right, thank you very much. We now move to Choma. Choma General.
Hello, Dr. Mpeta.
Hello, good afternoon.
Yeah, this is Moses Kings Kateka Mwanza from the Maternal and Child Survival Program based at Chipata District Office. I'm also joining the session.
All right, thank you very much. Kalabo, I think, all right, I think Kalabo is joined by, they have joined with Mongu. Is that so? Do we have anyone from Kalabo? Kalabo Enela Aban.
Yes, good afternoon.
Good afternoon.
Yes, it is Winera Clinic. I'm Joseph Simbotwe. Together with me are the supportive staff, Mr. Shuang on my far left, the right side, Mr. Nasre. Are you getting?
We are getting you, although you are breaking at times.
Okay, network here is the bad. I'm saying I'm Simbotwe Joseph, a nurse at this facility. And I'm with a peer volunteer, Mr. Nasire, and Mr. Shwanga, a supportive staff.
All right, thank you very much.
Yes, the rest of the staff members for outreach.
All right, thank you very much. Choma, are we ready? Choma, are we ready?
Someone is.
Okay, if Choma is not ready, can we move to Livingston?
Good afternoon.
Hello, good afternoon.
Yeah, this is Agre Mambo.
Yes, sir, we can get you.
I'm taking I'm with the band.
Yes, Livingston, can you go ahead? May I remind those who are not on the floor to kindly mute their microphones so that we can give only one center at a time to introduce themselves. At the moment, you have got Livingstone on the floor.
Good afternoon.
Good afternoon.
We see here Dr. Sombo Fellowship, our Chief Clinical Mentor, and we have Dr. Zico Mandla, ID Registrar. We're also joined with a team of mentors from different districts in Southern Province. And also we have the
all right. Thank you very much. Thank you very much. I will remind again, may I remind all of us, Nangongwe Clinic, we are muting you. Please, can you please mute your microphone? Okay, due to time, I think we will recognize all those who have joined us. That is Dr. Sivile Suwilanji joining there. We've got Dr. Mwangela Mubiana Mbewe. We've got Dr. Lloyd Mlenga. We've got Dr. Mary Boyd, who unfortunately, due to time, was unable to join us here in the hub. And then we also recognized Matelo Level 1. We recognized Nangongwe Clinic and Mungu Urban and Lewanika. And due to time, I think we'll straight away go into the case presentation. Today, we'll start with the case presentation, which is coming from Western Province. The case. Okay, so we'll start with the didactic as the case presenters are yet to join. And the case presentation will be done by Dr. Charlie Rwechungu.
Okay, good afternoon, everyone. We'll go straight into the care of the HIV-exposed infants. Next slide. Okay, so that's the outline of our presentation. So we'll start by epidemiology, and from the Zambia, we can see that in terms of testing, we are at 47%, and unfortunately, right down to viral suppression, we are way less than 50%. And then we are reminded that only half of pediatric patients are non-positives in Zambia, so meaning pediatric HIV is not doing too well, even with the gains that we've made. So in terms of PMTCT, the major things that should be done in antenatal include repeat testing every 3 months for the mother and repeated risk reduction counseling, especially for those who are HIV negative, but also for the positive ones. And also for those who opt out of testing, we need to do repeated counseling. And then for those we find reactive, we need to start them on combined ART and trace their partners and initiate them if found to be positive. We need to do TB screening. We know that pregnant women are particularly at risk of developing TB, so we need to identify that. And then certain things that are ignored in antenatal are discussion of the feeding options. And you find that when you start having feeding options when the baby is born, it's a bit difficult if these things were not discussed earlier. So the drugs that should be given to the infant should be discussed, as well as viral load done in the last 4 weeks of pregnancy, including minimally invasive procedures during delivery. So this is just a summary of the slide of one of the tables in the guidelines. But of what I want to emphasize is the highlighted column 2, which if you have a woman who refuses ART or one with established infection who's not on ART, you can suggest option B plus, option B if she refuses B plus. Option B is where we used to give her ART until the time she delivers, but option B plus is now lifelong. But then we have to remember that the baby needs to be on prophylaxis until the risk is gone. Okay. Meaning until the mother is virally suppressed, because the assumption is just that, is not just that if someone is on ART, then they are automatically virally suppressed. So postnatal care, once a mother delivers, we need to again start counseling on infant and young child feeding, the feeding options. And we'll go into that, what Zambia has recommended. We need to discuss what the drugs that the child will take. We need to continuously discuss adherence. Family planning needs to start even before a mother delivers, but definitely strengthened when she delivers. Hygiene, cord care, and danger signs. And these are discussion points that pertain even to HIV negative mothers. And then we need to give the mother vitamin A. And then once the baby is born, give AZT, NVP3TC, as well as the day one vaccines, which are OPV0, BCG to the baby, and do a birth DNA PCR. So in terms of the vaccination schedule, what we have highlighted there is the new immunization record that's still under a pilot. So what you note in there is that there's additional vaccines which are not in the current one, and that's HPV 1 and 2, which we'll be giving to our young girls. But the same pertains like what you have to an HIV negative child. So if you have, for example, OPV given at birth, it's the same. At 6 weeks, we'll give the pentavalent, which is Hep B, Haemophilus influenza, and then DPT, as well as Rota, and we'll also give PCV.
Next slide.
Oh, okay.
Sorry?
Another point to emphasize is that the same immunization schedules that apply to the HIV negative child will be the same ones that we'll do. Will be the same ones that we do even in the baby who's HIV exposed. So we mentioned that we need to do a DNA PCR, a NAT test at 6 weeks. We need to do one at 6 months. And then we also need to do one at 9 months. We start with serology. But under discussion now is the fact that, and it's something that we are yet to incorporate in the guidelines, is that we are getting children who are having false positive results, and hence the consideration for extending to do a DNA PCR at 9 months. And one other thing we've noted is that most pregnant women in MCH are not being tested every 3 months as per the guidelines. One of the weaknesses is the under 5 card that doesn't prompt people to do so. And so when providers see that this child is not exposed, they don't do that. So what you can see on the screen right now is the new card that's going to be rolled out shortly, which includes a section for the mother to be tested every 3 months. And it's going to prompt providers to just make sure that the mother is tested to identify those babies who could be reactive. So in terms of our national policy towards feeding is that we recommend the baby to be exclusively breastfed for the first 6 months, because this is the option that is widely acceptable, feasible, affordable, sustainable, and safe. It meets the AFAS criteria. From experience, the time that we tried to roll out recommendations for supplementation, we had a lot of children dying from malnutrition because a lot of them were being, they couldn't afford formula. Just last week, we had a child who was on Parmalat as a replacement feed, and that's what happens. So the national recommendation now is for exclusive breastfeeding and then transition to supplementing feed, and this breastfeeding should continue for 2 years. I think we can do our first polling question now. Polling question. So, question 1 says, regarding risk of mother-to-child transmission, it is preferable for all women to deliver by cesarean section. B, a NAT should be done at birth to detect the infants that may have gotten infected in the intrauterine period, and that NAT should be done at birth to detect the 5% of children that might get infected during labor. So the answer there is B.
Okay, we've been given the answer already, but those who haven't cast their poll may do so. And I think we have gotten almost 100%. We'll still give a few more seconds. Okay, so I think we've got 100%. Everyone has gotten the answer correct. And whether that was due to the answer given earlier, we don't know. But we assume that learning is taking place. Okay, so we can proceed with the presentation.
Okay, so the reason why we put up this polling question is because we realized that the NAT at birth is something that's not being followed. A lot of people are doing the NAT at 6 weeks, but the NAT at birth is not being followed. And the importance of doing that one at birth is that a 5% of children might be infected intrauterine, especially if the mother was not virally suppressed and not on ART. So we always advocate for starting ART as early as possible to achieve viral suppression so that we reduce transmission. We can go to our second polling question.
So the second poll question is, select the best answer for the following mother-baby pair. A, the two can be followed up in MCH for as long as the mother wishes to remain there. B, TDF, XPC, dolutegravir is preferred drug for the mother if not effective family planning. C, the preferred infant prophylaxis for high-risk HIV-exposed infants is nevirapine for 12 weeks. May I remind those whose mics are on, please, to mute them. You are giving us terrible feedback. Then the last one is D, the pair should be transitioned to ART department when the baby is 24 months of age. So we are giving up to 30 seconds for people to take part in the poll. So we have got only 10 out of 29 who have voted. Please cast your vote. We are at 34%. 10 more seconds. Okay, thank you very much. Dr. Chadilwe, would you like to say something about the poll?
Okay, so we have a lot of mixed answers, but the majority was D. So for us that picked A, I think in as much as we advocate for client-centered care, it's desirable that a mother be transitioned to ART when the baby clocks 2 years. And then in terms of C, what we give now in our guidelines is AZT, 3TC, and NVP. So single dose, we are no longer doing unless you don't have anything, but we recommend for getting access to those drugs. So we can go to our third and final polling question.
So the third poll question is, what measures can help us detect severe acute malnutrition? A, weight for height. B, weight for age. C, mid-upper arm circumference, MOH. And D, BMI for age. Our poll starts now. We've got 10 seconds. Five seconds for those who haven't participated. Three seconds. Okay.
Okay, so we have a lot of mixed answers as expected. And the reason why we posed this question is because when we go and do mentorship, we find that nutrition monitoring is very bad across facilities. So nutrition monitoring needs to be done, but then the smart care forms actually guide us, because the indicators that you can use for severe acute malnutrition are weight for height or weight for length. You can use a mid-upper arm circumference if it's less than 11.5, and you can also use a BMI for age. So weight for age is what you find in the under 5 cards, but it doesn't measure for severe acute malnutrition. It just tells you there's a growth problem with which you need to follow up with any of these other 3 indicators. So this is to just emphasize that can we do routine nutrition monitoring in ART to pick up kids that might be failing?
Okay, thank you very much. We can go back to the presentation.
Okay, so we mentioned that our current young child feeding guidelines, we advocate for breastfeeding up to 2 years, and we have to be reminded that if the mother has a high viral load, then we cannot discontinue the prophylaxis because this child is still exposed to the breastfeeding. But in terms of counseling our mothers, we are sending a lot of mixed messages because we need to tell them that once her viral load is suppressed, then the risk of transmission is reduced. And so breastfeeding is a good option, and especially that most of our parents can't afford supplementary. So the challenge of replacement include incorrect preparation, poor hygiene, and potential mixed feeding, which can encourage acquisition of HIV. So like I keep mentioning, feeding options are made easier when mothers are counseled in pregnancy, so that you don't have to leave that to the people delivering the infant to start discussing feeding options. So we need to discuss this in antenatal clinic. So in summary, we've seen that from our epidemiology, pediatric HIV really requires a lot of attention, and rightfully so. We need to prevent transmission, identify the children who are positive, prevent opportunistic infections, and maximize family well-being. These are, in fact, the pillars of PMTCT, and we need to use all available platforms that we have: TB preventive therapy, Septrin, in prophylaxis in terms of ART. We need to initiate those who are eligible, the IMCI platform, primary health care, and school health as well are all platforms to identify children. And then the success of eliminating mother-to-child transmission depends on family-centered care. what we've been noticing is the focus is so much on the woman, but if the family is not involved, then it becomes difficult to achieve EMTCT. And then facilities should have child-friendly services, including a champion for childhood HIV to help prioritize early infant diagnosis, adherence, and viral load. So in conclusion, we are all child health advocates, and let's do that.
Thank you very much, Dr. Chungo. And Dr. Chungo has rightly said that we are all child advocates, so let's put our hands together in ensuring that we eliminate mother-to-child transmission of HIV. I will allow a few questions just before Lewanika can come in to present the case for the day. So for any of us who have got questions, may do so now. We've got a written question which we'll start with. I think it's coming from Douglas Watson. And the question is, how commonly do clinics do MOH? How commonly do clinics do MOH?
So in ART, there's a provision for that on the smart care forms, including DMI. But like I mentioned, it's something that's been wanting.
Sorry?
I'm saying it's wanting in the sense that people don't comply. But it's something that definitely we need to.
So the other question is that what should be the standard in Zambia?
So the standard, so may I mention that MOH is validated for children less than 5 years of age. So that's a standard. Usually for ART, it's a bit difficult to do weight for length in an ART setting, but in the clinic setting, we do weight for length. So the standard in Zambia is weight for length or weight for height, but a MOH is a quicker indicator where you have staffing challenges like we do in most of the clinics, and it will give you a good snapshot.
The other written question from Mongo is a bit unclear. Would you kindly just send us that question again? Anyone from the spokes who has any question for Dr. Chungo's presentation? Yes, there's a question actually from here, the hub.
Okay, thank you. It's just a contribution because the focus is so much on the mother. But there's another group of low-risk babies. These are mothers who have HIV positive pregnancy. In such a case, it's recommended that NAT is done on the mother. If it's positive, NAT has to be done on the child as well. But if it's negative on the mother, she has to be put on prophylaxis, and that way the baby will be protected.
I definitely agree. And if NAT on the mother is positive, it means that baby is automatically high risk because the mother is a new infection, meaning that that's a mother who would be on ART for 12 weeks or longer. And in that table that I projected, that scenario was there, except I was just highlighting the sec. But that's a very, very important point. Yes.
Thank you so much.
Okay.
Thank you very much. We've got a hand from Rodrigue Kikwiva. Yes, you can go ahead.
Yeah, good afternoon.
Afternoon.
Okay, we have this situation where a mother tested negative in antenatal. She tested again negative 3 months when she started family planning. But at 6 months, because she was sick and she wanted to be seen through the routine testing, she was found to be positive. So she was enrolled on ART, but the question was, what do we do for the child? Because this is a child who is high risk of HIV, and if we have to start prophylaxis, is it going to be for how long? And is it that we have to advise maybe stop breastfeeding or whatever? So I want to hear from you, what can be the advice for that child? But the sample for now was taken. It's a case of Friday.
Okay, I will allow Dr. Chalilwe to come and tackle this question when we do the case. I think similar discussions. So hold on to your question. If we happen to forget, you can still remind us. Thank you very much.
Okay.
Okay.
I have a question.
Well, sorry, where's the hand?
I have a question.
Okay, you can go ahead.
Yes, this is Moses from Eastern Province.
Yes, Moses, you can hear you.
Yes, I just needed a clarification from Dr. Chungu. That was a very good presentation. I just needed the clarification on the epidemiological statistics that he referred to in terms of Zambia. Are we still using the 2016 Zambia report for that? Thank you.
Thank you very much.
Yes. So I use the 2016 Zambia, but of course we have latest data, especially in view of a lot that has been done in terms of surge activities. So because of the Lusaka surge, definitely those indicators have gone up, but pediatrics is still wanting in terms of viral suppression and also in terms of linkage.
Thank you. We've got another question, I think the last one from Livingstone, and we have unmuted you. You can go ahead.
Good afternoon.
Good afternoon.
Yes, this is Jean from Livingstone Central Hospital. I just wanted a clarification on the prophylaxis that we give for high-risk baby. So according to the guideline for the So according to the guideline, the SZTGBTC, the Verapine, should be given for 12 weeks for a high-risk child. But I'm looking at this mother whose viral load is above 1,000. Is it always that we should stop at 12 weeks, or we can continue until the mother is suppressed? Thank you.
Thank you very much, Livingstone, for that. I've been advised that this is being discussed together with the case, so you can hold on to your question, and we're going to discuss with the case. I have one written question, and I think this could be the last one. And the question is coming from Chilenje. The question says, I've seen that the upcoming antenatal card includes HIV testing at 3, 6, and 9 months. Why not using colored stickers instead of writing because of stigma? I have noticed that when the HIV status is clearly written on the cards, mothers tend to lose them. The other one, I think, is coming from Sony, and is saying it's better if we use ICD codes with colors. So that's, I think, in response to Chilenge. I don't know if Dr. Charlie, you've got something to say about that.
Yeah, so this document that I shared with you is actually in draft, and we are still getting openness with the HIV testing, but we will look into that. Okay, we will look into that, and we'll definitely put that into consideration as the further drafts keep coming up.
So I think we can have more discussions after we look at the case. So I will ask IT to put up the case from Lewanika, as Nomsa will be introducing the people who are giving us the case presentation from Lewanika.
Okay, Lewanika General Hospital, thank you so much for the effort. I know you've had some IT issues, but thank you for the initiative you've taken. So we have a team from Iluta Health Facility, and they'll be presenting a case. They are joined at Lewanika General Hospital. So the presenter is Lukonga, the clinical mentor. Lukonga, we've so you can go ahead and present. Lukonga? Lukonga, are you still with us?
Yes, can you get me?
Yes, we can. So
Okay.
you go ahead. Yeah.
All right. So we are going to take a case. That's a mother-baby pair. The case is coming from Ilute Clinic.
Can go to the next page. We're using your screen.
Okay. So the mom is a 22-year-old, started ART 7 years ago. She denies any history of single-dose NVP exposure and says she takes her medicines every day. She is not in formal employment. Household income is between 500 to 1,000 per month. Husband was followed for index testing. He declined an HIV test, insisted he is negative, so no documented status. Next slide, please.
Projected, go ahead. Are you able to see the next slide?
No. I'm using your screen. Okay. So the baby is 9 months old, received AZT, PTC, nevirapine from birth up to 8 weeks. DBS was done at 6 months. On that one, we also did DBS was done at 6 weeks. It was negative. 6 months, it was also negative. She's still breastfeeding and takes supplementary foods as available in the home. Has an 11-year-old sibling who tested negative when followed up by index testing team. Another sibling died in 2002 from febrile illness. Next slide.
Can you see the next slide?
No, not yet.
Yeah.
I'll continue. I'm using another laptop. The slides are delaying. So physical examination for the mother. Weight was 48 kg, height 150 centimeters. BMI was 21, RR 18. The BP was 107/70. HR 71 beats. Then she had enlarged parotides. For the baby, physical examination for the baby. The baby appears to be happy, healthy, able to stand supported, interactive, length not done. The weight was 6.8 kg. No oral thrush, no lymphadenopathy or edema. Available results. HIV test was positive for the mother. The first viral load was done on 17th March 2018, which was 1,356 copies. The second viral load was done 24th May 2018. It was 2,506 copies. Then the third viral load was done on 4th September 2018. It was 2,486 copies. So no chemistry results. On the baby, DBS was done at 6 weeks, was negative. 6 months, DBS was negative. 9 months and body, it was negative. We sent another sample for DBS pending results.
Together with the mother, we got a sample for viral loads, pending results. So our question for this presentation is, in view of ongoing exposure, should we put the child back on ART prophylaxis? Would an earlier switch have been better than enhanced adherence counseling? That's for the mother. The mother was enrolled in enhanced adherence program. So we are asking if it's a switch, that's to second line, was it going to be a preferred step to take? Then is the breastfeeding cessation an option in this child? Thank you very much.
Hello, Nomsa.
Sorry, I think our mic was muted. We have now opened it up for questions.
Okay,
so do we have any clarifications concerning the case? Okay, we'll start with the hub. I think there's a question within the hub. Please, you may go ahead.
Thank you for your presentation, Dr. Mutuma. So I would like to, I have a few questions. Why was prophylaxis for the infant given just for 8 weeks? Sure, based on our guidelines, we have a different duration depending on the risk of the infant. If it's low risk, it's 6 weeks. If it's high risk, it's up to 12 weeks. Second question is, why wasn't the DBS done at birth? And my third question is, have you screened the mother for TB, looking at the fact that she has enlarged carotids and she's already failing ART? Thank you.
So thank you very much, Dr. Mutuma within the hub. Now we'll give chance for Lukonga from Lewanika to give responses to those clarifications by Dr. Mutuma.
Okay.
Lewanika?
Yes. So for the DBS,
would you kindly try to mute the video, blunt the video maybe? Okay. Kindly, yeah, turn off one gadget so that you remain with one. We avoid feedback.
Okay, can you get us clearly now, Dr. Mpeta?
You are clear.
Okay.
Go ahead.
For the DBS at birth, at the facility, she was only offered the antenatal services. She delivered from somewhere else, where it seems like the DBS at birth was not done. At Ilute, she only came at 6 weeks. That's when we had to capture her at 6 weeks. The 6 weeks results were out and they were negative.
Hello, Dr. Mpeta.
Thank you. We can hear you. Yeah,
yes, and then planning for the prophylaxis, which was given for 8 weeks, we are not sure on that one. Yes, we know that the high risk we're supposed to go for 12 weeks and the low risk 6 weeks, but we are not sure why the clinical practice there, they are done 8 weeks. So this is more like a prospective case presentation. So only to find that the patient only took for 8 weeks the prophylaxis. And then in regard for the TB screening, from history, the patient had no any constitutional symptoms. The only noted physical finding was the parotid enlargement. So ideally, we did request for chest X-ray, but constitutionally, the patient didn't have any constitutional symptoms, but definitely we'll pick it up from there.
Okay, thank you very much. I hope that is clear. So we'll ask Livingston. I think they have their hand up. Livingston, you can go ahead.
All right, thank you so much. Can you get me?
Yes, we can.
Questions. The first question is, we've seen that a series of viral loads were done, but maybe just to clarify, moving together with the timeline of the baby, at what age of the baby was the first viral load done on the mother? Was she pregnant or she had already delivered? That was my first question. Then my second question, I think according to the slide of available results, we can only see the adherence program being offered after the second viral load. That's after the second. Oh, okay. Anyway, I've just been corrected that it was actually done after the first. I thought it had been done after the second. So I wanted to ask why it wasn't done on the first viral load. On the first viral load. And also why we kept doing viral loads despite signs that there was clear viremia in this patient. Thank you.
Okay, hello, you can get us? Lukonga can answer the question.
Okay, I'll answer the question for how old was the child when the first viral load was done. So the first viral load was done on the 7th of March, and the baby was born on the 2nd of March.
Would you please kindly turn off one gadget? We're getting feedback. You are good to go.
Yes, can you get me?
Yes, we can get you now.
Okay. Answering the question where it was asked, how old was the child when the first viral load was done? So the child was born on 22nd March, that's 2018. Then the first viral load was done on the 17th of March, 2018. So the child was about...
It was in pregnancy.
Yeah, so the viral load was done when she was pregnant. She was still pregnant. The first viral load was done when the mother was still pregnant.
We have unmuted. Mwanza, we have seen your hand. You can go ahead.
Hello.
Hello. Yes, we can get you.
Yeah, I think we can get back to the last slides. I just wanted their clarification on the way they were doing their viral load, because we can see from the presentation that the first viral load was done in March, and then in May, and in September. And I don't know if the guidelines were followed, because now these were 3 viral loads that were showing to be increasing, meaning that the viral load was not reducing, it was increasing. So I don't know where they are saying now in November, the viral load is pending. So I just needed a clarification on that.
Okay, so in short, are you trying to find out why they kept on doing the viral loads and not intervening, like the earlier question, is it?
Yes, Doc.
All right. Lukango, would you just kindly try to clarify why the center continued doing viral loads when there was a clear case of treatment failure?
Okay, I feel, okay, upon speaking this case, we feel they had, maybe they never had enough light on how to go about the high viral loads. So they kept on requesting for viral loads. And I think they never had knowledge on how to act upon the high viral loads.
Okay, so thank you very much. Yes, so what this case was, I think, discovered by a lower facility, a rural health center, and that's why they have come here so that we can discuss and assist them. Remember, it's not every center that will have access to, specialized services, and hence the need for us to share this. So probably if there aren't any more clarifications, we now move to the next stage, which is the discussions of the cases at hand. I will ask people in the different spokes to contribute before we can ask our subject expert, Dr. Chungu, to comment on the case and summarize before we can call it a day. So I can see a hand from Livingstone. I think you can go ahead and contribute on the case, on the questions which have been raised by Lukango and team for us to discuss and see how we can assist this facility.
Good afternoon. I'm Dr. Zico, IT registrar from UTH. I'm visiting Livingstone. So I would like to tackle the question about which was the preferred option, whether enhanced adherence counseling or the switch to second line. We're dealing with a pregnant woman. And so at this point, it's not only actually her we're dealing with, but the unborn infant as well. And so at that point, as soon as the high viral load was determined, a switch to second line should have been made, especially that no contraindication was found and no opportunistic infection was found in the patient. So a switch to second line was the best course of action that should have taken place as soon as they found the high viral load in the patient. Thank you.
Thank you very much, Dr. Zico. We can have another contribution from Dr. Sivile. Dr. Sivile, you can go ahead. Kindly unmute your microphone.
Hey, can you get me?
Yes, we can get you now.
Okay, thank you very much for allowing me to contribute. I must say that I probably partially agree with Zico, not entirely. The question that I'm having is, what was the outcome for the adherence counseling process? Yeah, of course, adherence doesn't have to take many days. Sometimes it can take just one single session. But what kind of sense did they get from this woman? Was the woman taking her drugs? What were the issues? I think that's the starting point than rushing to switch. I think those details will be very helpful in this discussion.
Okay, so thank you very much. I think Dr. Sivile is concerned, trying to get a clarification. Was the issue of adherence about the woman not taking the drugs or not, rather than us rushing to switching? Lukango, I don't know if you have got any insights about that. What was the outcome of the adherence counseling? Did the woman start being adherent, or the non-compliance continued? Lewanika.
The woman started being adherent to treatment. Hello?
Hello,
Yes,
Dr.
we can get you. Yes.
Hello, Dr. Yes, so from the information we're having is that the patient became adherent to the medication because we're looking at a situation where she's coming from a family where the husband is refusing testing and she's the only one taking the medication in that home. So those challenges also were considered in putting her in adherence other than a direct switch. But from the information we're having is that the patient became adherent to medication.
Okay, thank you very much. So Dr. Sivile, I hope you have heard that the woman indeed became adherent, but the other issue is that the husband refused testing of any sort and hence could not be taken up into care. So any more thoughts on the questions that are raised? So before we give Dr. Chungu to give his thoughts and summarize. Pata, any thoughts? Oh, Chilenje. Chilenje, you can go ahead. Yes, good afternoon.
Yeah, good afternoon. Yeah, I just want to talk about.
Try, Chilenje, try to get close to the mic. You are a bit faint.
Are you able to hear us now?
Yes, loud and clear now.
Thank you, Dr. Mupeta. So my concern is about the husband who refused to undergo the HIV testing. What was plans? Because we've been expecting this man to, the adherence counseling to continue until he accepts to be tested. And in the meantime, maybe to give them condoms so that the transmission of HIV to the woman can be stopped.
All right, thank you very much. Lukango, was the patient provided with condoms so that we can avoid reinfection from the partner? Would you give any thoughts on that? I think that's the question from Chilenji.
The woman was provided with condoms, but there are some situations whereby the husband would refuse to use the same condoms.
Cannot be established. Hello?
Hello?
Yes, you said whether the condoms were used or not. We did not hear that part.
I was saying the condoms were given, but there are some situations where the husband refuses to use the same condoms.
Okay. So thank you very much. So I think this is a a complicated case socially. We know that on the other hand, the husband was refusing care and indeed was also refusing protection. So it's something that probably the health facility couldn't have much to do with that regard. There is a hand coming from Kalabo. Kalabo, you can go ahead.
Yeah, thank you so much. I just want to find out maybe from the presenters, Lewaneka. According to the record, you noticed that the client has been on the CAT for 7 years. So even when we look at the labs that were done in terms of the viral loads, I wanted to find out or maybe to ask if they followed the profile to see if the viral load of late has been done or not, or what has been the profile like for the viral load. Otherwise, the issues may be to do with prophylaxis. I haven't heard them talking of issues to do with septrin, or if this client was due for septrin or not, so that we rule out issues of OIs for this client. And then also in terms of the viral load, I noticed for this client, it was supposed to be done earlier on. So what is needed is maybe to have probed further in terms of these investigations, not leaving out CD4 issues, so that we can know the prophylaxis which the if the client was supposed to be on Septrin or not. Thank you.
Okay, thank you very much. Although we've been asked that we should focus on both the mother and the baby, I don't know when you mean this client, whether you're talking about prophylaxis in the mother or in the child.
Yes, I'm talking about the prophylaxis to the mother because the viral load was done for the mother who was on ART for 7 years. Meaning that if you were to give the prophylaxis for the child, we're supposed, this child could have been given prophylaxis for 3 months. Not the 2
So
months.
Yes, I think that was explained that it's not known why prophylaxis was stopped prematurely, as the patient was found in a remote area. And hence, that's why the case was brought here to discuss, to see how we can assist this facility. So I think that was the explanation given. We'll give chance again to Livingstone to contribute. And then if we don't have another contribution on the questions raised, I will ask Dr. Chungu to look at the questions which have been raised by the facility and see how we can conclude with the case. Livingstone? You can go ahead, Livingstone.
This is Edgar, clinical mentor from trauma. Our plan was on breastfeeding. Since the child is already receiving mixed feeding, should we continue with breastfeeding? Looking at the weight of the child's weight is not very good. So that was our concern. Thank you.
Okay, so let's what they think about this case. So maybe we'll pass it on to Dr. Chaliwe to talk about breastfeeding and mixed breastfeeding, if this child should continue with the type of feeding that they are on with regards to the risk that is currently there. So I will invite the last contribution before I ask Dr. Chaliwe. We've been informed, I think, coming from the study that is done by PEPFAR, they found that the results were not different from the Zambia 2014. So the question which was asked earlier, whether we should stick to the Zambia statistics, as of now, there isn't much different with what has been done recently by PEPFAR, which found that only 53% of children living with HIV throughout Zambia had a viral load and less than 50% suppression. So the statistics haven't changed much with what PEPFAR found this year in June 2018. Then I think the other one's contributions has to do with the partner testing, of which I think Dr. Chungu will highlight. I take it that there aren't any more contributions. I now invite Dr. Chungu to look at the 3 cases which have been asked and in light with the current discussions, and also just to talk about the importance of index testing, especially in this particular case, and how that is important in the elimination of mother-to-child transmission.
Thank you. I think this is a very good case because it highlights a lot of the challenges that are faced in caring for the mother-baby pair. First of all, we are faced with a father who declines to test, which is a common challenge. And if you remember, we talked about family-centered care. So all avenues to try and get all family members on board should be explored. And then one of the things we see is that in rural settings, that there's a very good platform for this because people engage traditional leaders, chiefs, and there's definitely more success in index testing in rural settings than in urban settings because people are more receptive towards traditional leaders, and that's a very strong platform which we can learn from in the urban setting. Also, to highlight that some of the challenges that are faced out there these might seem like straightforward issues, but then here we have a mother who had persistently high viral loads and to which the response was not given. It came out also that initially mother could not have been adherent, but then with counseling, adherence improved. So I agree with Dr. Sivile that the need for adherence cannot be overstressed. The success of ART largely depends on adherence. So after adherence was secured, and we have a high viral load from the last 4 weeks of pregnancy, intensive adherence, this client should have probably been switched to second line. But also to add that viral load in pregnancy should be done when, in first trimester at 6 months, and then in the last 4 weeks. The emphasis here is in the last 4 weeks, but then we're not told on when she started ART also. So that could also be a derailing factor in the sense that if maybe she's
7 years ago.
Yes, so if she started antenatal late, then it's a missed platform for you to do the viral load testing in the last 4 weeks of pregnancy. So definitely, in view of what has been presented, if adherence had been assured, this client would have benefited from an earlier switch. I think that's what we are hearing from everyone. That's a unanimous opinion. The second is that in terms of feeding options, what should guide us is food security. The decision to stop breastfeeding is not one that should be entered into with haste. And looking at the type of setting that this client comes from, she comes from a very rural setting, which I doubt that she would be able to have access to clean, boiled, cooled water, should have access to an uninterrupted supply of formula. And so at this point, there might not be much benefit from cessation of breastfeeding. This scenario typifies what we explained when we said that for a mother who has a persistently high viral load, even though the guidelines say that 12 weeks, if the viral load is still high, this mother is still very much a high risk in terms of transmission to her baby. And so, even when the decisions were made to switch or not, the decision to continue with prophylaxis should have still continued. I think in our guidelines, there's a scenario which says if a mother refuses ART, and we highlighted on that one, it can be extrapolated to this scenario, but this is different in the sense that if she has a high viral load, in which case we should try and intensify adherence and make a switch. So in this scenario, there is benefit on continuing prophylaxis. So what to do now is in terms of the way forward. Since adherence has been assured, I think this mother could benefit from second line. That's number one. Number two, this baby can continue to breastfeed. In terms of prophylaxis, we have negative DNA PCR, so baby can continue on AZT, 3TC, and NVP until cessation of breastfeeding, up to which point we can continue doing the testing. And if baby becomes positive, then we'll be eligible for initiation. I think those were the pertinent issues. Then another thing I also wanted to state was, in line with what we're saying about nutrition, the length for this child was not done, which is what's happening out there. So a MIWA could have been helpful. And then the other thing was in terms of the color coding that we suggest for the mother-baby pair. You know, it might seem like a temporal measure, but with time, the community will know what the color codes mean. And then we'll go back to square one in terms of, do we now need to change the color coding to other color coding in terms of stigma? So those are certain things that we need to think about as well. I don't know if there are other additional comments from the spoke or from the...
Yeah, so thank you very much, Dr. Chungu. On the color coding, I think it was earlier suggested that why don't we use ICD-10 codes in terms of exposed or infected mothers and children so as to avoid stigma. But like Dr. Chalilo has said, with time, we have got very literate people in the community. They'll still learn the ICD codes. So it's something that we have to work hard to stop and ensure that stigma is not there in the community for us to have, enhanced treatment. There was a question, I think, which Lukango, I don't know if you can address. The mother had been on ART for 15 years. 7 years. 7 years with those high viral loads. The question was, I think this is for everyone, wasn't the mother supposed to be switched early? And I think Dr. Chalilwe has talked about this, where this mother would benefit with an early switch. And I think a PI is probably what could be advocated for. Dr. Mlenga and Dr. Suilanji Sivile are asking if there is any role of use of dolutegravir in this patient, especially in view of trying to accelerate the viral load, decrease. Maybe we can have anyone within the hub or the spokes to contribute. Dr. Zulu, any role of dolutegravir in this patient?
Yeah, so as for the use of dolutegravir, it would be a good option to drop the viral load quickly, and that will eliminate the option of the child being subjected to extended prophylaxis with the AZT nevirapine. Because once the mother is then suppressed, the child could be taken off that prophylaxis. But the other thing that needs to be looked at while we put the mother on the DTG is the risk of her having a next pregnancy. So, of course, we need to put in issues of sexual reproductive health, making sure she's on adequate interventions in terms of not conceiving, whether a long-term family planning method, preferably an implant, or even an injectable, especially that the husband, she has no control over condom use, so preferably an implant or an injectable. But DTG could be used if we can assure that she won't get pregnant while on the DTG.
Yeah. And maybe just while you're at it, Dr. Zulu, and how do we balance, the case of treatment failure, and especially that if this woman could be on DTG and then getting exposed from this husband who has refused to come into care, how do we look at that?
So the issue with this pair is that with the husband refusing to access care, there are many things, including PrEP, that will not be strategies for this man, since you do not know his strategy, his status. You do not know his status, so you cannot even offer PrEP. Then in terms of condom use, she has very little to say. So there are all those issues. But on the issue, will the DTG work? It definitely will. But we do not know what the exposure of this man to other drugs could be. Is it that it's possible that he could be accessing care elsewhere and not taking it properly, hence having a resistant virus that he could transmit to the wives? Those are all questions that we could not really answer unless we get more detail while counseling that couple. But knowing that if he's on a drug like DTG or even the PI that was mentioned, which are drugs usually with a higher genetic barrier, they would probably help in covering the woman from any infections coming from that side.
Wow, thank you very much, Dr. Zulu, for that contribution. And I think in closing, Dr. Sivilia has said that dolutegravir could actually be withdrawn once the woman has suppressed, so as to give a chance without any fear for her for future pregnancies. There's a hand from Dr. Mlenga. Okay, kindly unmute Dr. Mlenga.
I'm
Dr.
sorry.
Mlenga, you're welcome. Thank you.
Thank you. I'll be quick to make this comment. I strongly feel that the woman should have DTG, and as Dr. Zulu has said, contraception effective. But also, the fears over the use of DTG in pregnancy are now becoming less and less. And I think in March there will be guidance which the program and also the global world also is going to receive over DTG use. So let's try and encourage the use of DTG where possible with expert consultations. To me, I think that would be my message to especially the teams out there.
Sorry, there's another hand.
Mary Boyd.
Mary Boyd. Yes, Dr. Boyd. Thank you very much. I think that would be the last.
Thank you. Sorry, I just wanted us to go back to the baby for a minute. There are some questions going through the chat about whether this baby should go back to the routine prophylaxis, the triple drugs, or is there a role to think about a different prophylaxis regimen? If that could be clarified, please.
Okay. So I think Dr. Chungu said something in his remarks, and I think I'll ask him to say a bit about the breastfeeding cessation in this child and the continued prophylaxis in the child, considering that we have recommended a switch for this mother and addition of dolutegravir.
So I get Dr. Mary Boyd's concern in the sense that should we then put the prophylaxis on second-line drugs? But then we don't think that would be a very good option, because remember, this is the prophylaxis that the child was on before and never contracted. So yes, we know there's concerns about activity, but there's still a bit of activity in terms of viral suppression. So I think the unanimous decision, the unanimous advice here is that the child would still benefit from the AZT, BTC, and nevirapine, rather than going to an alternative prophylactic regimen. Probably from hearing the discussions, I think a DTG would quickly lower the viral load. We continue that until we can repeat and then stop.
All right.
Yes.
That would be the last hand, Dr. Thomas.
Sorry, this is Dr. Thomas. The prophylaxis, I think there is a consent to continue the AZT, 3TC, and BP, the three drugs together after 12 weeks, considering the mitochondrial toxicity. So we are thinking in terms of giving NVP alone after 12 weeks, but we are thinking that it may come after approval. But at the moment, the current guideline says the three drugs, even for prolonged periods, but it may change.
All right. So thank you very much. So the current guideline says that even for extended periods, we give the triple drugs, which is subject to change anytime soon. I think with this and contributions, the last we need to address is how is the facility going to actually access the dolutegravir for this woman. I think through the supply chain, which is, as this is coming from the hub and the expert opinion has been given, so this patient, that is the woman in question in the case, through the supply system should actually access dolutegravir on a named basis. Dr. Zulu, any insight?
I think you have already alluded to the fact that it's very possible for them to do that. It's just an issue of the district, then provincial pharmacy to access. That can be done. But meanwhile, if the DTG might take long, they can switch to a PI-based regimen, which will be readily available.
All right. So thank you very much. So the switch to a PI should be done immediately, and then the dolutegravir should be acquired through the district and provincial pharmacists. This has been a fruitful discussion from the hub, myself, Dr. Mpeta, my co-hosts, Nomsa, and Dr. Chungu, who has been our expert for the day, would like to say goodbye. But before that, I think there's an announcement from Nomsa.
We also, as we conclude, we just like to thank Lukanga and team, and maybe they can have last comments on how you feel on the discussions. If you have any questions, there will be a recommendation sent to you, but we want to give you an opportunity because you are dealing with a real case, and probably if you have any questions or any comments from the discussions. Lukanga? Lukanga?
Okay, first of all, my name is Lukonga.
Oh, Lukonga. Lukonga. Okay, Lukonga.
Yes, would like to thank you. The discussion was fruitful. At least now we have the recommendation and we go and work on them. And for DTG, Lewanika has it, so it won't be an issue. Thank you very much on behalf of the one.
Okay, thank you so much, Lukonga, for that case and your team. And we're happy that you got some information. I mean, the discussions was fruitful, and that you will receive a written recommendation and follow up with the patient. So thank you, everyone in the network. We just want to remind ourselves that we are on again next Monday, and we will have a discussion on early infant diagnosis. And then all of us from the facilities particularly, please, can we have the register sent in soon as you can, those that participated. And thank you so much.
Thank you very much.